So good evening, everybody. We are here from the EIZOC Secretariat, ready for the Ophthalmology Resident Teaching Series 26. Our topic is today, Approach to the Orbital Surgery Part 2. I welcome all our speaker, Dr. E. Ravindra Mahan, the moderator, Dr. Gyan Bhaskar, and we had the panelists, Dr. Anirban, Dr. Jayita Das, Dr. V. Varsha, and Dr. Rajesh M. Chaudhary. This is an effort of EIZOC led by our Chief Coordinator, Dr. BNR Subudhi sir, guided by Dr. Ajit Babu Maji, and all our team of EIZOC executives are ready. With this, I welcome everybody and request our president to give the welcome address.
Thank you, Dr. Swaraj Bhattacharya. This is the ORTS number 26 in continuation, and the topic has already mentioned, approach to orbital surgery. This is the part 2. Part 1 we had a couple of weeks back, and we have the same speaker, Dr. E. Ravindra Mohan, an old friend of mine. He's an honorary professor to MGR Medical University in Chennai. The session will be moderated by Dr. Gyan Bhaskar from IJMS Patna. And in the panel, we have Dr. Anirban Bhaduri, Dr. Joita Das, Dr. Varsha B, Dr. Rajesh Kumar Chaudhary. And amongst the discussions, we have doctors from various medical colleges of the East and beyond. EIZOC is extremely grateful to mentor Dr. Ajit Babu Manji, Chief Coordinator Dr. BNR Subudhi, Secretary Dr. Swaraj Bhattacharya, and Chairman Scientific Committee Dr. Sabyasachi Patnaik for having burnt midnight oil all the time. They have been spot on, and it is because of their untiring effort that this ophthalmology resident teaching series has been so successful. With these words, I also wish and welcome all the audience. And before I wind up and give it over to Dr. BNR Subudhi, there's an announcement that we have the EIZOC annual conference coming up in November, on November 29th, 30th, and December 1st. That will be hosted in West Bengal, and the place is a very nice place, Kalimpong. So everyone is invited to attend the annual conference. With these words, I hand over the space to Dr. BNR Subudhi sir, who is the Chief Coordinator for the program. Over to you, sir.
Good evening.
It's coming.
Yes, it's coming now.
Yeah, yes, it's coming now, sir.
It's
changing the slideshow.
Yeah. Okay. Thank you, our President, Dr. Pranab Ranjan ji, and Dr. Swaraj Bhattacharya ji, our Secretary EIZOC. I welcome you all once again to our EIZOC ORTS 26 program. And today's the speaker is with us, Dr. E. Ravindra Mohan. We had similar program, or rather, with Dr. Ravindra Mohan last month, and he has really gave a very nice talk on proptosis and approach to orbital tumors in the last episode, and we want to hear from him the second part, the orbital surgery approach. And this is the EIZOC team. President Dr. Pranab Ranjan, Secretary Dr. Swaraj Bhattacharya, and our Chairman Scientific Committee Dr. Sabyasachi Patnaik. So this team, we have done wonderful work for the postgraduate students since last few years. So many programs, every month 1 or 2 programs to update the residents about the different various subjects in ophthalmology. And of course, choosing the topic and choosing the speaker really credit goes to our mentor, Dr. Ajit Babu Maji, wonderfully selected speakers. We have seen the last few years, wonderful speakers from each nook and corner of our country. Thank you, sir. Welcome today once again to our program. And today's speaker is none other than Dr. E. Ravindra Mohan. Already he was with us in the last month, but still then to recollect, memorize his biodata, I will let me speak few words about him. He is the honorary adjunct professor, Tamil Nadu, Dr. MGR Medical University, Chennai, the founder director, Trinetra Eye Care, Dungamakam, Chennai, the senior consultant, MGM Healthcare, Chennai, Greeningles Global Health City, Chennai, and Palmer Sankara Hospital, Chennai. He obtained his MBBS degree from the prestigious All India Institute of Medical Science, New Delhi, followed by residency training in ophthalmology at the same place. He worked as a senior resident in the division of oculoplasty, orbital surgery, and pediatric ophthalmology, AIMS for 3 years. After that, he joined Sankaranathal as a consultant in October 1998 and is appointed head of the department, director department of oculoplasty, orbital surgery and trauma in April 2005. And after that, he left Sankaranathal to start Trinetra Eye Care Center at Chennai. He has over 100 paper presentations, over a dozen poster and video presentations, has delivered over 200 invited talks, including named orations. There are 2 dozen publications to his credit, including those in the prestigious journals like Survey of Ophthalmology, Eye, Orbit, Ophthalmic Plastic and Reconstructive Surgery, and Indian Journal of Ophthalmology, as also book chapters. He has performed life surgery at a number of national and international meetings and been a chief instructor at a number of innovative instruction courses. He has been executive member and secretary of Oculoplasty Association of India, advisor for appointments to various senior ophthalmologist positions in the government of India too. He has been a surgeon to the governor of Tamil Nadu and invited surgeon to the president of India. Dr. Ravindra Mohan is a reviewer for a number of index journals, including the Indian Journal of Ophthalmology, Journal of the American Academy of Ophthalmology, Middle East African Journal of Ophthalmology, and Ophthalmic Plastic and Reconstructive Surgery. These are the few I have selected from his biodata. I welcome you, sir, once again to our EIZOC episode 26. And today's moderator is Dr. Gyan Bhaskar from Patna, is IGMS Patna, is additional professor, RIO. And panel consists of Dr. Anibal Bhaduri, is the currently at the oculoplasty, ocular service of Susruta Eye Foundation at Salt Lake, Kolkata. And Dr. Jaita Das, senior consultant, oculoplasty and orbit surgeon at Desai Hospital, Kolkata. Dr. Varsha V, currently she is an orbit and oculoplasty specialist, chief surgeon at Sankaranathal, Chennai. And Dr. Rajesh Chaudhary is almost with us since the last few episodes, currently senior consultant ophthalmologist Netralayam, the super special eye care center, Mukundapur, West Bengal. And today, I think voluntarily so many postgraduate students came and joined this program. Dr. Purbasa Panda and Dr. Sasmita Mishra from Bimsar Burla, Dr. Lakshmi Saju and Dr. Sravani Sarkar from Silchar Medical College and Hospital, Dr. Subhasri Sahu, Dr. Vivekanand Sahu, Dr. Spotiranjan there from MK's Medical College, Berhampur, and Dr. Ekta and Dr. Pankaj Sukla from Jain Medical College, Bhagalpur, and Dr. Rishabh Seth from Ruby Eye Hospital, Berhampur. So these are the postgraduate students who have been volunteered to come and join this program. I wish that they should interact with our speakers and the panelists. So with these few words, I welcome you all once again to our EIZOC Ophthalmic Residency Teaching Series number 26. Now it's over to Dr. Ajit Babu to say a few words before it goes to Dr. Gyan Bhaskar. It's over to Dr. Ajit Babu.
Yeah, thank you, Dr. BNR. Without wasting much time, we should move on with the topic. And I request all the postgraduates to ask the questions because last 1 hour session 2 weeks back, Dr. Ravindra Mohan was very interactive and he was very approachable for even a basic question. So that ask any doubts you have so that the 1 hour is utilized to the best. With these few words, I want to give the microphone to Dr. Gyan Bhaskar.
Thank you, sir. Thank you, everyone. Good evening, everyone. Thank you so much, BNR Subudhi, sir, President Dr. Pranav, sir, Suraj Bhattacharya, sir, CSC Patnaik, sir, for this opportunity. Today's topic of discussion is very important, not only for the youngster, but also for the oculoplastic surgeon. We frequently encounter challenge in the surgical approaches to the orbital surgery And often we rely on our radiologist colleague for the localization and the easiest approach. Certainly, after today's talk by the highly experienced and eloquent Dr. E. Ravindra Mohan sir, we will be much oriented toward the same. Now, I invite Dr. E. Ravindra Mohan sir to begin his presentation. Welcome, sir, and please start, sir.
Thank you, John. Thank you, Dr. BNR Subudhi sir, Dr. Pranav sir, Dr. Ajit, and all dear friends and young ophthalmologists who are attending the session. So this is what I labeled as
Share your screen.
yeah. Just Is it visible now? Is the screen come?
No, it's getting started.
Yes.
Visible.
Yes. Okay. I'll just put it on the full screen.
Yeah.
Is
Full
it okay?
screen. Yes. Now it is all right.
So to have a recap, the last session was a very basic one on basic anatomy of the orbit, the applied anatomy, the approach to history taking, which is very important in orbital surgery. History taking is important in all aspects of ophthalmology, but in orbital surgery, it's particularly important for many reasons that we described earlier. And some basics of examination. So I think all postgraduates who have been more than a year in ophthalmology would possibly know most of it, but the youngsters may possibly need to go back and look at either look at the video or learn examination from their seniors. Now, the important things to understand when we operate on the face is the need to be able to access the tumor. In this case, we are only talking in terms of tumor because I think fractures will get treated differently, orbital infections will be treated differently. So we'll concentrate on removing something from the orbit, essentially a tumor. So relaxed skin tension lines are lines of skin tension present when the skin is in relaxed state. And these are the result of basically interaction between the internal and external factors. And a knowledge of these is very important, not only for orbital surgery, but when we are doing any surgery around taking out a little lesion around the eye or doing anything else, we should know that the scar would be least if you cut around these lines. So in this, for example, when we make incisions, it should not go across the relaxed skin tension lines. And those which are buried well in these configurations will lead to a much lesser scar. So when we are doing the skin incisions for skin approach orbital surgery, these considerations are important. Of course, there will be other considerations also. It cannot just be this consideration. But today, aesthetic surgery is not only about a watertight compartment wherein we are looking at aesthetic surgery as a separate standalone, but also in every functional surgery, there has to be an aesthetic thought process so that we give a minimum scar to the patient. Now we start with the different approaches to different quadrants or different sections of the orbit. Now, medial orbit is classically through a frontoethmoid incision, also called the Lynch incision. So the Lynch incision is in the superomedial quadrant, and this is called it's a workhorse incision which has been used for things like frontoethmoidal mucocele and any lesions in the superomedial orbit. This has also been used for things like optic nerve sheath fenestration. We know that the optic nerve can be easily accessed through the medial orbit because of the direction of the optic nerve. Now, what is the disadvantage of this medial approach through a incision? Is a cutaneous scar with a webbed appearance. We know from our experience in DCR that if it's not well made or if it's too long, then there can be a webbing in the medial corner. There's also dissensation of the medial canthal tendon or damage The superomedial orbit is a surgeon's bugbear in orbital surgery because of the rich blood supply and the nerve. So you have the supraorbital nerve, we have the trochlea, we have also a rich blood supply. So be careful about the superomedial orbit whenever you are doing any surgery. And also if you go too down, then you can damage the lacrimal sac. Medially, we also have what is called as a transcarancular approach. Now, this is, we will come to the minimally invasive surgery a little later. We know the caruncle is a beautiful structure and it is very important for us cosmetically. There are certain patients where we need to do a surgery to replace the caruncle in its right place, because if it is not done, it is almost always picked up by somebody else. So it's cosmetically very important. But the advantage for the orbital surgeon when going through a transcaruncular approach is that it is relatively bloodless. So one can go from incision, it can be a pre-caruncular or a post-caruncular, but one can go from incision to reach the orbit in 2 to 3 minutes flat. Because once you incise, there is hardly any bleeding, and one can retract the tissues very well and reach right up to the medial orbital walls, like in a decompression surgery. So this is, for example, the anatomy which shows how some of the points that I made earlier, that if you go through this area through the caruncle, you are basically going through a very relatively blood-free or free of blood vessels on any important structures. So there are no important structures. One can incise and one can just insert your dissectors and go very quickly. And if you're doing a medial orbital wall decompression, you can do that. If there's a tumor in this area, you can access it. It's a very good incision. Now, the caruncle, for example, is divided and dissected, and one can see the arrows which go right up to the bone. So if you have an abscess, you have you have to remove the medial orbital wall for some other reason. These are very good incisions. A transcaruncular approach avoids a visible scar. So that's important. So sometimes as ophthalmologists, we don't give much importance to structures like the caruncle, but still I think postgraduates should know something about the anatomy. What is the plica semilunaris? What is the embryological importance of that? And so on and so forth. So these transcaruncular approaches preserve the integrity of the medial palpebral tendon. It avoids the damage to the lacrimal sac and provides an excellent exposure to the medial wall orbital contents. Now we come to inferior. What if you have, for example, an inferior orbital mass which you need to biopsy, or you think there is a large cavernous hemangioma sitting inferiorly? So there are multiple incisions. So some of the incisions I think the postgraduate should know is the one which is 2 millimeters away from the lash margin. From the lashes, if you measure 2 millimeter and make a nice incision along the skin tension, relaxed skin tension line, this is called, this incision is a very, very useful incision in the sense that it is virtually unseen and it doesn't scar. Then there are incisions which are a little further off, including the infraorbital incision and some incision along this crease. You can see that these are all following the same principle. Also, you may need to go along further, and this kind of a shape which respects the skin to relaxed skin tension lines is important. Now, here also you can do a transconjunctival incision. So instead of going through the skin and 2 millimeters from the skin or incising the skin, one can actually incise the conjunctiva and follow a transconjunctival approach, because the scars, we know that the eyes are, the periocular area is very important from the aesthesis point of view, in the sense that if you see a person for the first time, you're going to spend almost 90% of the time looking at the triangle formed by the eyes and the nose. So even the most minute scar is going to be visible, noticeable. So we cannot take any scar as being irrelevant. And I do not believe that any age is free from the need to avoid a scar. Even the elderly appreciate if you avoid giving them a scar. So this is, for example, the way we do an incision through the inferior approach, wherein you can divide the conjunctiva. Today, many times in the transconjunctival, we are using radiosurgical incisions, which virtually don't bleed, and we have a bloodless surgery. That means there is less postoperative edema as well. In the inferior approaches, there are multiple ways of reaching depending on where you want to reach. So this is the subciliary approach we mentioned, 2 millimeters from the lid margin. It's a workhorse incision which has been used by orbital surgeons, oculoplastic surgeons, blepharoplasty surgeons facial-maxillary surgeons to reach the contents of the lower lid, inferior orbit, and floor of the orbit. So subciliary approach is a good approach. This is not to criticize by saying that no skin incisions are bad. I'm not saying that. Subciliary approach is a very good approach, done well. But we know as oculoplastic surgeons that if you don't do surgery delicately, for example, if you take long bites and you are little rough and you take long bites or cause more scarring, then it can be unforgiving, because the more the scar, the closer to the lid margin, there can be an ectropion. So one of the risks of skin incisions close to the lid margin is an ectropion, which is not a great result to have, and you may end up with an unhappy patient. So one has to be careful. It's subciliary, it has to be done delicately. There has to be fair enough amount of training and supervision before one does the subciliary routinely. You can have a pre-septal incision wherein you will not go and open the septum. Now, what is the problem of opening the orbital septum? If the lesion is within the orbit, then you cannot avoid a septal incision. But if you are, for example, going to repair the fracture of the floor, then opening the septum releases a lot of the fat, because the septum is the structure which keeps the fat behind and out of view. And if you open up the septum like this or like this, then all the fat will come out. So in fracture surgery, we tend to try and avoid incising the septum and going preseptally and reaching the floor here. Whereas in surgery to remove a tumor, let's say a hemangioma from the orbit, one has to go transseptal, and there is no way you can avoid opening up the septum. So we see that the conjunctival, transconjunctival incisions have some advantages. They have the lowest rate of scar-related complications. They have given very aesthetically pleasing results and can be combined either with a lateral canthotomy or cantholysis and a transcaruncular incision with greater degree of access. And access to the orbital apex is difficult, and we need considerable skill when we are doing this. So we'll come to some of these points as we go. Now, what is a lateral canthotomy and what is a cantholysis? I think it's important to spend a little bit of time on canthotomy and cantholysis. The canthotomy is dividing the canthus, which we usually in the earlier days, what we used to do is to straight artery forceps, clamp it at the lateral canthus, which is a relatively avascular structure. So there's not so much bleeding, but as you dissect deeper inside to cut open the inferior crust of the lateral canthal tendon, there can be bleeding. So one must have a good bipolar cautery. Once you divide the lateral canthal tendon and do an inferior cantholysis, you can also do a superior cantholysis. So once you do an inferior cantholysis, this is a surgery, then the eyelid, and if you cut the eyelid along the conjunctiva, you will have what is called as a swinging eyelid, and you will get a lot of exposure, particularly to the inferior orbit and to the lateral orbit. One point that I would like to make to young postgraduates is that even though we have a lot of topical surgery going on now for cataract, but at times peribulbar is much safer, but at our time used to have what is called as a retrobulbar injection. So I'm sure there are retrobulbar, some indications you would have seen or you would have noted, but in that, if there is bleeding and there's a lot of orbital hemorrhage, that's an emergency situation. Not only after a block, but even orbital hemorrhage, for example, in a road traffic accident, and you have tense orbit, which can compromise the blood circulation to the optic nerve, then a lateral canthotomy and cantholysis is a sight-saving operation. So I remember that we have saved some patients' sight by doing a canthotomy and cantholysis in time. And so if there is, for example, a hemorrhage, if the maxillary artery or some other complication your ENT colleagues may have, or you may have after a block which has gone wrong and there's a tense orbital hemorrhage, canthotomy, cantholysis is the way to save the vision, and that we should all know. Now we come to the big topic of lateral orbitotomy. So I'm not going to go into too much of detail about it, but some of the principles which all of you must know. Lateral orbitotomy, we know that the lateral orbit or the lateral orbital wall is the most deficient orbital wall. So the eyeball is relatively less protected the lateral side because part of the eyeball is exposed laterally. We know that. So the lateral orbital approach is the way to reach intraconal space. So conventionally, if you get a question says what is the best approach to reach the orbital apex, or to reach an intraconal mass or some mass which is around the optic nerve, then the answer to that question is lateral orbitotomy. So you can't do a medial orbitotomy and reach the area. I mean, these are standard teaching. There are ways in which surgeons can innovatively reach many places from many other places, but the lateral orbitotomy is the way to reach an intraconal tumor and also the way to reach the orbital apex to the extent possible. So there are multiple incisions available, but basically this is called the lazy S or a modified Stallard right incision. So we've seen, for example, our teacher, Dr. Betharia, do a lot of these operations with a lazy S incision. So it is a subbrow incision, it goes in and it comes a little, it's a longish incision, it's a very visible scar. And this is followed by this is the temporalis muscle and fascia. So we have to really retract it well. And then we come to the bone and periosteum. We have to divide the periosteum there, cut the bone, take an osteoplastic flap, take a piece of the bone out, then cut the periorbita. And once you cut the periorbita, often the tumor will come into view. And then we remove the tumor, make sure there is no bleeding, put the periosteum back, put the bone back. And sometimes in the bone, we make beveled incisions so that it can be put back nicely. And then often in these kind of an orbitotomy surgery, because the risk of bleeding, one more point that I would like to make to all the young trainees here is that orbital surgery has certain really big risks. One of the big risks is that you are unable to locate or adequately treat bleeders. And if in the postoperative period, the patient has bleeder and you've repaired these incisions well in a very nice watertight way, the pressure can build up and cause compressive optic neuropathy and loss of vision. So in every orbital surgery, there is the small but definitive risk of loss of vision. So orbital surgery should not be taken lightly, and any experienced orbital surgeon would have at least one or more patients where the vision has been compromised or even lost. So in this lateral orbitotomy, lazy S incision is one. Of late, many people use an incision along the lid crease. You can approach virtually everything along the lid crease, and we know it is a normal line all of us have. And if an incision is hidden along it, then the scar is not seen as something separate. So you can skin lid crease incisions. Lid crease incisions are very aesthetically pleasing for virtually all operations. But you need a larger area of exposure since you need to remove bone. I would also like to emphasize here that the lateral orbitotomy can be done without cutting the bone also. For example, if there is a lacrimal gland tumor, which is a large one, you may be able to access it without removing bone. But in many cases, especially for intraconal or apical, we need to cut the bone. So we mentioned about placement of a drain. So what in the orbital surgery we used to do, or we used to assist and observe our teachers doing. So there is a negative suction drain, like placed by the GI surgeons and urologists. There's a small drain which is negative vacuum drain, which is put and which comes out of a separate stab incision, and that has a vacuum, and that slowly the blood fills up. And when the blood stops coming, we remove the drain. So today's surgery avoids all that, in more or less. It's been a very long time since I did a bone flap removing lateral orbitotomy. We'll come to that in a short while. So how do you close the skin? You should close the skin without any tension. There should be accurate approximation. There should be no raw surface and atraumatic tissue handling. This is true for any surgery, whether you're doing ptosis surgery or you are even repairing a lid laceration. These must be borne in mind. So this is an opportunity to emphasize these points once again. So there should not be any tension. You somehow manage with a thick suture to put it together, tie it up. That's not a good way, because over time, the wound will tend to gape, and that will be full of collagen, which will lead to a bad scar. So sometimes you see when a patient comes in, they're fallen down, it's not been well repaired, there'll be a bad scar. And some of those patients, we do scar revision as well. The approximation should be accurate. Of course, there should be avoidance of a raw surface and atraumatic. So these are skills that we need to pick up. So now lateral orbitotomy, inferior orbitotomy. Superior orbitotomy again can be done the same way as a lateral orbitotomy through a lid crease incision. The lid crease is the most aesthetic it is like a blessing to an oculoplastic surgeon that we have a lid crease, because we can hide our incisions in it, and then we have to retract and do things. Sometimes we need the help of a neurosurgeon for superior orbital, because sometimes the orbital bone is deficient, and if we do any extensive procedure through the orbital approach, one can encounter dura or even worse than that. So there may be a need for a bicoronal flap, which you all may have learned as in your surgery posting. So bicoronal flap, and that scalp is brought down, and that the bone is removed, and the tumor can be approached from removing the roof of the orbit. Now we come to what is minimally invasive orbital surgery. I think, in my opinion, this has revolutionized orbital surgery. And over the last 20, 25 years that we've been doing it, it has given a much more safe and predictable outcome to the patient. We learned about the conjunctiva and caruncle, which offer excellent portals to reach the tumor and remove it. So we know the conjunctiva. Conjunctiva is a friend for all the ophthalmologists. We handle, we mishandle, we sometimes tear the conjunctiva, or sometimes we may do many things with the conjunctiva, but it is very forgiving tissue. It will grow very quickly in the matter of hours, and overnight or within 24 hours, the cells have migrated, it covers, and you can't even see the scar. So this is one thing that we are going to use in minimally invasive surgeries. And much reduced hospital stay. So today my average orbital surgery patient stays just overnight. That is because I'm still a little apprehensive of sending them home in the evening, because patients come from far and wide, and we don't want any complication because of our keeping our ego above the patient interest. And the case selection for these minimally invasive orbital surgery is important, and it's not a one size fit all. So I'll walk you through some of the important aspects. So why are we so? I mean, is it vanity? Is it arrogance? Is it too much of beauty consciousness that makes us go for minimally invasive surgery? The answer is no. Given a choice, you give a choice to an elderly person in your outpatient, whether they want a scar on the face or they don't want a scar. The answer is going to be very clearly, nobody wants a visible scar. You also are possibly doing the surgery much faster and more precisely performed, healing, and lesser downtime. Today, people are going to ask you how many days do I have to take leave. So that is important. And this can be performed as a short stay or even as a daycare procedure. Now we come to the conjunctival surface. So we know the eyelid anatomy, something which is very, very important for all postgraduates to be able to draw the diagram of the upper lid cross section, the lower lid cross section, what structures, where is the levator inserted, and where does the molars muscle attach. So those things are, I think, pretty much standard. I'm sure the anatomy talks and your own self-study, you will be able to go through these. I wanted to emphasize some aspects of the conjunctival approaches. So this is the palpebral conjunctiva, this is the fornix, and this is the bulbar conjunctiva. We predominantly work in orbital surgery at the fornix or into the palpebral conjunctiva. We very rarely cut the, we don't do a peritomy or cut the bulbar conjunctiva in most cases. Now, this is the diagram I'm talking about. This is absolutely standard diagram, which you must know. Every postgraduate should be able to get up from sleep, woken up, and they should be able to draw this diagram well, because you know the anatomy of the lid. All the understanding of your eyelid surgery can be based on these two diagrams. So everything that is written in standard books, you will understand, provided you understand the balance of these two laminae of the lid. So this is the fornix through which you can, the fornix is sitting next to the orbit. So the lower fornix is here, the upper fornix is here. And this is the caruncle, which we also saw earlier, how quickly one can enter the, so in my opinion, of course, this is not opinion everybody may share equally. There may be difference of opinion. I feel one can approach any corner of the orbit through a transconjunctival approach. Of course, the only exceptions that I talk about are apical lesions, because right here, from here to go to the apex, you're possibly causing too much of globe displacement. You may cause too much of retraction, which can be dangerous. So other than apical lesions, virtually everything else can be removed through a transconjunctival approach as well. Now, these are some of the very, very early patients that I started with over 20 years ago when I was a very young consultant in Shankar Netralaya. And this is a girl with a large lesion here. And this is the patient after surgery, which was one of my very first transconjunctival approach operation. And this was very thrilling because if I went through a regular approach, I would have had to be cutting either a subciliary or an infraorbital, most probably infraorbital incision. But here we did not do that, and we did a transconjunctival approach. And this was one of the very great joys of doing the surgery in this place. Another young lady who came in with a large mass here. Again, if we followed the conventional teaching and did what we were trained initially to do, we would possibly be going along this, removing it, but leaving her with the scar. This is the appearance of the patient day one post-operative. This is how she is. Edema, everything will go away, and she'll have a very, very good appearance later. So some of these patients, for example, this is the second patient. You can see it's a fairly large lesion, and that has been taken out. Now we'll walk through some of the patients of minimally invasive orbital surgery just to expose you to what is possible today in the realm of orbital surgery, because I think day and night postgraduates are bombarded with topical phaco and anti-VEGF and all the good things that ophthalmology has to offer. So I think we must expose them to what oculoplasty also has to offer and how different things. So I'm sure other speakers in other areas are also going to do that. I think that's the way they will be updated and not just learn whatever is written in the older textbooks. So this is a patient with a large proptosis, and one can see easily that all the postgraduates and young ophthalmologists know that this looks like an axial proptosis. There is no obvious displacement, and it seems to be a big bulging even on a 2D image. And this is the patient through a transconjunctival approach. The surgery has been done, the tumor has been removed, and this is the appearance at the end of surgery. So I did a lateral canthotomy. I did a cantholysis. I have not put too much pictures because we'll run through some other patients as well. There's some bruising, etc. The pupil is a little dilated, but all this is perfectly fine. Now, this is a patient. We have a video. I think if it plays in the end, we will use that. These are again large tumors. See, these were all conventionally. I don't think there would be any discussion at the time when I was a resident that we have to do a lateral lateral orbitotomy, maybe a modified Staladrite type of incision. So at this time, since I mentioned these names, the postgraduate also should know some of the named incisions. Today, there is a general movement in science against named procedures, named incisions, because the French describe it differently. The British will write English textbooks, they become popular, or the Italians will not, they may have done it earlier, but their name doesn't come. So there is a general movement away from named incisions, but some of these are pretty much so standard that it may be good to say that. So modified Staladrite incision, we talked about lateral orbitotomy. There's a straight cut, like a lateral canthotomy extended back, that's called a Berkey incision. The Lynch incision in the superior medial is called, it goes by the name of Lynch, and so on and so forth. So we may come to this lady a little later. So I'll go through some of the slides we show. This is the tumor that the person had. It's a huge tumor. It's displacing the optic nerve up. This is the CT of the tumor. It's well defined. So in orbital surgery, there are two things. One, is it well defined or ill defined? If it's well defined, you try to get it out safely. If it's ill defined, infiltrative, no attempt should be made to take it out completely, because you may end up actually losing vision for the patient. So this is the patient who's undergoing a transconjunctival approach. These are called malleable retractors, which have copper and they are malleable, and these are very important. So orbital surgery is one area where we need very good assistance from our team, surgical team. We also often need hypotensive anesthesia that will reduce the blood pressure, reduce the bleeding. We need good assistance, good lighting, and good, you can do it under microscope. So often I do orbital surgery under microscope, but you can also use a loop magnification. So there are at least two assistants retracting, and this is what is called a typical cavernous hemangioma coming into view and slowly being removed. So like I often describe that when you remove a tumor, it's like delivering a baby. So we were always told never to pull the baby out. So tumor also never pull it out, because if it has got some attachments to the optic nerve and you give it a pull, you will end up with instant loss of vision, because the blood supply of the optic nerve is always very tenuous. We know that the blood supply of the optic nerve is very tenuous, and you pull it and it shears off the covering, the pile covering, and you may have blindness. So orbital surgery is very delicate, despite some of the images which may look a little gruesome, but it's very delicate and it has to be done extremely delicately. Sometimes we use cryoprobe. My own teacher, Professor Bitharia, was very fond of using cryoprobe to take it out. I don't, in many of the multi-specialty hospitals I practice in, we don't have a cryoprobe, and we found ways of pushing the tumor rather than pulling it. So never pull, always only gently push and dissect it. And this is a tumor which is almost the size of the eyeball at about 30 millimeters, 25, 30 millimeters. These are the size of the eyeball. So we know the volume of the orbit. Any of the postgraduates can say, I'm sure all of them should be knowing what is the volume of the orbit. And so in a volume of about 30 ml, so this is a significant amount as big as this. Now this is a young, so some of these we will walk through. This is a young army officer who came with the left proptosis. One can see that there's significant amount of proptosis. Now these are actual situations where sometimes I'm asked that you're so bothered about scar. What happens if there is a small scar? I will tell you what happens if there's a small scar. He was an army officer. If he got a scar, he would be downgraded on the physical fitness level, and he may never get a promotion and may get a desk job. So because of that reason, he went from pillar to post to try to get a surgery without a scar, and finally he reached me. And then I said, okay, let's have a look at him. So this is the Nafzager view. So I think this is something, again, some of the examiners may be fond of asking the postgraduate as to how you will pick up mild proptosis if you don't have a Hertel's, for example. So this is the Nafzager's view, wherein if you lift up the chin of the person standing at the head end, one cornea, in this case the left cornea, is coming into view much before the right. So basically the eyeball is pushed. So this is the Nafzager's view of the patient, showing a good amount of proptosis. And there's a huge mass here. It's a huge tumor filling up the intracorneal space. And this is the lateral sagittal view, showing it kinking the nerve. You can see the optic nerve is kinked like this, tumor sitting there. And obviously, if you leave it for too long, also compressive optic neuropathy is a real risk. So these are some of the other views. And you can see the optic nerve. This is much more nicely delineated. So when you're going to be doing any surgery, for example, if there are attachments or adhesions between the tumor and the optic nerve, then one would get, if you are a little rough, even if you are gentle, you may have a loss of vision. So that's a real risk orbital surgeons face. And there's another component of vision loss, which I think postgraduates should know, and that is called the Steele syndrome, STEAL. So Steele syndrome means, after all, a cavernous hemangioma like this is a vascular lesion. So there is a theory that when you move it, it steals away blood from around the optic nerve and reduces the blood supply of the optic nerve, and there can be a loss of vision. So there's a risk of Steele syndrome, there's a risk of actual traumatizing the optic nerve, and so on and so forth in this kind of a tumor. So this was taken out. This is the size of the tumor. This was taken out through a transconjunctival, transcaruncular approach. So I cut the conjunctiva, I cut the caruncle, and then retracted the tissues in the way I showed you with copper malleable retractors. And this is the large tumor. This is the appearance at the end of surgery, where all the tissues are placed back. I often don't use sutures at all in these patients for the simple reason that the conjunctiva knows where to go. If you have a conjunctival laceration today and it's not gaping, tomorrow you call the patient for review, you can't find where the cut was. So the conjunctiva knows where to go. So we put it back. And sometimes I found in the early part of my work that putting the suture actually worsens it. You may get a symblepharon and things like that. You leave it open, there are two advantages. The first advantage, instead of putting a drain, this acts like a self-draining orbitotomy. If there is blood, there is an egress point. It can come out. If there is no blood, the conjunctiva will go back and heal. So it's a self-draining kind of an orbitotomy. And the tissue is being placed back very gently, very carefully. And this is the patient when he came to me after 6 weeks with the tumor removed, no scar. So that is the practical advantage, wherein the scar can do harm to a patient. And if you can give a scarless surgery, that's always better. Now we come to some interesting cases wherein this was a child who was in utero. So the mother went for a routine scan to find out, the organ development and all that, which all women have to go through. And then the people found a large retroorbital cystic lesion. And there was a lot of discussion between the pediatrician, the gynecologist, the ophthalmologist, whether the pregnancy should be terminated early to prevent damage. So finally, the patient had a delivery at the normal time, but it had a very tense orbit. So the child was born in another city, and then they did a lot of finding out and talking to people, and they finally came to me in my clinic. And this was a child. So I had to decide two things: whether to do a surgery at all for this child at this age, because child is a neonate, not yet 4 weeks old. And but the orbit was very tense. So I said, if the orbit is tense and we just do masterly inactivity, it's finally going to end up in a child with poor vision. So we, with good anesthetic preparation, we went in and did the surgery. So these are some of the intraoperative pictures of a neonate, which is very challenging from the anesthesia point of view. And one can see that there's a large cyst, retrobulbar, retroocular, which is causing compression. So this is the exposure this is the incision for a lateral canthotomy and cantholysis. And these are some traction sutures. And with the canthotomy, all the unbelievably delicate handling these tissues. So even the smallest instrument looked like a big thing there. And this is dissection. Again, the thinnest malleable retractors have to be used, and then the small tense mass comes into view. That is dissected. One more thing that I would like to emphasize is that in orbital surgery, we always monitor the pupil, because if you put too much pressure on the optic nerve, you could end up with dilating the pupil. Of course, there can be pupillary dilatation even if you damage the efferent pathways. For example, if you are moving around the ciliary ganglion area, but still it gives us some kind of an idea of the pupil dilates. This was one of the biggest challenges when assisting orbital surgery of our professors. And also, even now, the pupil has to be dilated. One person has to monitor the pupil, certainly. So this is the mass coming into view, and we decompressed it and removed the tissue. This was luckily a large tense cyst lined with respiratory epithelium. And in this case, we put one single absorbable stitch. As I said, we leave it minimally invasive. We leave it self-draining. And this is before surgery, and this is after the surgery. And this is the child data. So the child is now about 5 or 6 years old. So this is a kind of an overview which I thought would give some aspects which possibly may not be covered in the standard textbooks of ophthalmology, and also which may be of some interest in the sense of something new.
Thank you so much, sir, for your nice and elaborated talk. We have an expert panel. May I request our panel for any comments or addition? Please.
Before going to panel, maybe Ravindra Mohan can ask some questions to the postgraduates.
I think their names are not being displayed. Okay.
No, I can help you with the names. No problem.
We have the names.
Okay. So candidate number 1 can tell us the what is the volume of the orbit, since we already mentioned about it. Volume of the bony orbit.
Parbasha. Dr. Parbasha.
Sir, 30 ml.
Wonderful. Correct. What is the approximate volume of the globe? Eyeball.
Parbasha, again for you.
Sir, 20 around.
20? 20 out of 30 is a globe? Okay.
Sir,
Anybody else? What is the volume of the eyeball? Especially in
Sashmita.
enucleation surgery, it's very important.
Sashmita Mishra.
Sir, 17 ml.
Very wild guess. Okay, next. Much less than that, almost a third of that. So the volume will not go too much into too many candidates, and embarrass them if they don't know the volume of the globe. So the volume of the globe is about 6 ml. Okay, out of which vitreous cavity would be about 2/3. That's about 4 ml. So this is very, very important when we are doing an enucleation and we have to replace the volume with an implant, right? So I think you guys need to go back and read the anatomy. I always say that ophthalmic residents have to read so little anatomy compared to a radiologist, a general surgeon, or even a gynecologist. So I think you must read your anatomy well. Okay. Then,
Sir, may I ask one question, sir?
sure, please. Yeah.
Sir, how can we decide which approach is the
Introduce
best?
yourself first.
This, sir.
Introduce yourself first before
No, Gyan needs no introduction.
Okay.
Gyan is the boss at IGM.
Okay. Right.
Sir, how can we decide which approach is the best approach for the tumor, sir? Intraorbital tumor. Sir.
Right. Now, I think there are 2 or 3 considerations which we need to look at. We know that when we use an approach, we should not cross diagonally across the orbit, because there is the globe and there is the nerve. So whichever quadrant is the mass, you should try and be in that quadrant.
Yes.
So that's important.
Shortest route.
Shortest route is possibly the best route. Now, if the shortest route is not possible, then you may have to use a little longer incision. So in this skin approaches, if you are comfortable, see, it depends a lot on the, for example, in the medial orbit, one possible thing which I missed enumerating is the fact that medial orbit is accessible by endoscope as well. So nasal endoscopy is a way to reach the medial orbit. For example, one has a large abscess in the medial orbit. Your ENT surgeon colleague, or even you, if you are doing endoscopic surgery, could go through a medial approach and decompress the abscess, or even take a little biopsy. But I still feel that an open approach done by an oculoplastic surgeon is possibly the safest, and you will do a more complete job when you're doing it. So endoscopic approaches are good. There are also scarless approaches in the medial orbit. Superiorly, if it's close to the bone, there is some defect in the bone, you would want to have a neurosurgeon along with you, or at least sitting in the doctor's changing room, waiting for you to call them in case there is some leak of CSF or the dura is damaged. Lateral orbitotomy, standard orbitotomy is very, very safe and good, but it has certain limitations that we advise. You can approach the optic, anything around the optic nerve, intraconal space, and apex of the orbit. So transconjunctival approaches do not reach up to the apex of the orbit. Apex of the orbit is a very difficult area to reach by any means, certainly by transconjunctival. So lateral orbitotomy possibly gives you the best access to the apex of the orbit. Inferiorly, there are no problems because the inferior fornix is a very, very safe area to operate. So skin approach versus conjunctiva, as you get more confident doing conjunctiva, you may do it. But still, there can be wrong case selection. There was a few slides which I deleted because I thought time may not be enough. If you do a transconjunctival approach without adequate exposure to the procedure, or you do it for a very deep lesion which is located within the bone, for example, like a deep dermoid, then I have had some patients who have had incomplete removal at some other place, and then they come with inflammation, and then one has to do an open surgery and remove it. So case selection is important. Whatever works well in your hands is good, but I think at the training level, they should know all the approaches. They should be able to draw a diagram. You can get a long question which says what are the approaches to the orbit. So, and the idea of relaxed skin tension lines, the bones of the orbit, which I don't think we'll ask today, but during the fracture class, whoever is taking can ask those questions.
Thank you, sir.
Thank you.
Any question from our PGs? You can ask without any hesitation. Sir is here to answer all the questions.
Ravindra Mohan, I will ask.
Sure,
Minimally invasive orbital surgery. What are the components? Which cases do you select to do this? And what is the advantage over standard incisions?
So minimally invasive is basically a form of scarless. For example, in Dr. Ajit Babu's area of vitreoretinal surgery, we are constantly going from larger to smaller ports for vitrectomy. In cataract surgery, we're going from 5 or 10 millimeter to 5 to 3 to 2.8 to 1, and in every field. This is a trend not only. So this is the way the medicine is evolving. And today they're removing thyroid through an axillary approach, through the axilla by using endoscope and so on and so forth. So there is a role for reducing the size of the scar, visibility of the scar, surgical duration, hospital stay, potential risks and complications. So all these are to some extent achieved by minimally invasive surgery. But case selection, as I mentioned, if one tries to approach the apex, it is far too traumatic. The advantage of the conjunctiva caruncle is that every corner can be approached. If you just imagine that there's a tumor somewhere or a growth somewhere, you can go either through the caruncle or through that quadrant of the conjunctiva. So this is a newer way of thinking. So approach-wise, anything in the anterior orbit, inferior orbit, lateral orbit, superior orbit, medial orbit, all this can be approached. Intraconal also selective cases, because it should not become more traumatic than doing a lateral orbitotomy and removing the bone. Because after all, vision is the most important thing. If you compromise that, then there's a problem. Apex is difficult for an orbital surgeon. At times, for apical lesions, I have had to take the help of a neurosurgeon colleague and work together. So that way, minimally invasive has all these advantages. The only limitation is also the exposure can be good, because once you can actually incise 360 degrees of the fornix theoretically and come out and put the tissues back, and the next day all the tissues have gone back. So that is the advantage of the conjunctival transconjunctival.
Sir, often we face with the orbital fat. How can we encounter with the orbital fats during the surgery?
Yeah. So orbital fat is it's impossible to do anything without orbital fat coming in if you are working within the orbit. The only place where you can keep fat completely away is when I mentioned when you're doing fracture surgery. If you go through a preseptal approach and you retract the fat and the septum behind. So if the tumor or whatever you are working on is within the orbital contents, there will be fat. Everywhere behind the septum, there is fat. So the important thing is good retraction. So you saw in one of the pictures that there are three retractors in place. So the aim of those retractors is to keep fat away. So instead of putting the retractor like this, sometimes you may have to even put the retractor like this, so that almost all the fat is kept away. But it is certainly a thing. Excising the fat is not an answer, because more and more will keep coming. Good hypotensive anesthesia, Gyan. Good hypotensive anesthesia, good assistant. So these are areas where your residents and fellows have to be good assistants. As in ophthalmology, most areas they have forgotten how to assist. So they have to be good assistants. Hypotensive anesthesia, good lighting, and because we can't use.
What is the target blood pressure for hypotensive anesthesia?
Yeah,
I'm sorry, I am asking for the benefit of the residents.
No, sure. I think in most cases, when I see the blood pressure on the monitor when the anesthesia,
yeah.
So something like 90 by 60 and things like that.
60 by 100. Yeah. 100.
Yeah. 100 by 60 or 90 by 60 and all.
Yeah.
Based on age and other things.
This is for the because we are talking about hypotensive anesthesia and we are not giving the residents the idea of how much the blood pressure should be during hypotensive anesthesia.
So what are the pre-operative investigations apart from the imaging and ultrasound that is essential for these kind of surgeries?
Yes. So the patient has definitely to be fit for general anesthesia. In addition, I almost always, in most hospitals, serology, that is hepatitis B surface antigen and HIV are almost always tested. But of course, HIV with the patient's consent as per law. The other thing that we need to do is to rule out at least any kind of an occult or undiscovered bleeding tendency, because we are working in such a vascular area that it can be catastrophic. So we normally earlier we used to ask for BT and CT, bleeding time, clotting time, but that doesn't reveal many things, and we've burnt our fingers in the past, especially in DCR. So we do bleeding time, clotting time. We also do prothrombin time and activated APTT as well. Some people would, if there is anything abnormal in that, you may need to do an entire coagulation profile. So that is very important. If you are cutting bone anywhere in the orbit, and as we mentioned, we cannot cauterize deep in the orbit because you may catch structures which are important. There can be a nerve in it. There can be tissue sometimes in the intraoperative, because there is this shape and the size does not permit so much of exposure. So you may leave some bleeders. Actually, physically, there may be some bleeders still left when you're closing up. So it is important that all these clotting and bleeding parameters be checked. Serology for HBs, AG, HIV to be checked. And then the patient should be fit for general anesthesia. I think these are broadly the blood tests that would be needed.
Presidents.
Sir, I have a doubt. Sir, actually, as you mentioned earlier that when to remove a tumor, whether the margins are well defined or not, and what to take care of at that time. So, sir, what will be the the disadvantage or the problem we can face if we remove a irregularly defined tumor?
Very good. That's a good question. We all know that if it's like a ball, like some of the cavernous hemangiomas that you saw, some of the schwannomas, some of the well-defined tumors, you have to remove it and remove all the adhesions to the other structures and remove it. So it becomes pretty much straightforward. When it is infiltrative, ill-defined, for example, it is, it can be a fungal infection, for example. It can also be some metastatic deposit, for example. So in any of the infiltrative lesions, you would want to get a histopathological diagnosis. For example, it's a fungal infection. Once you take a piece of the tissue large enough to give you a diagnosis, the rest of the management is going to be medical management. So you are aiming at a biopsy or a histopathological diagnosis. Similarly, if you come to know that it is a metastatic lesion and it's all over, then you would want a diagnosis and then treat it. So the risk of debulking or extensive surgery is that you may have severe bleeding, your endpoint is not clear, and in fact, there is a large study on the number of patients who have lost vision, right? So that's called the devil's touch. So if a patient has lost vision, all the patients at Moorfields Eye Hospital who had lost vision in orbital surgery were analyzed by one of the top surgeons there. And what he found was most of the patients had lost vision when they were operated for these kind of infiltrative ill-defined. Because the surgeon will not have an endpoint. You keep removing more and you keep cutting more and removing more, and then you put the muscle away and then you keep doing it. So that is very, very, very risky in terms of your endpoint is not clear, and you may suddenly find that you've caused some trauma, you have damaged the muscle, there's squint, there is damage to the levator, etc. So in that sense, ill-defined infiltrative tumors is important to do a biopsy and debulk very safely. I mean, we have all done debulking, but it has to be done very safely, not aggressively. Also, another point which I thought, since you asked the question, is that we have something called intraoperative diagnosis. Now, there have been cases in the past, even with very senior orbital surgeons, that they have done a 3-hour surgery, removed the bone, taken tissue, sent it to the pathologist, and 5 days later, the report comes that it's all normal orbital tissue, there is no tumor. So it's a nightmarish situation to happen. Today, we are fortunately lucky in the sense that we have intraoperative tissue diagnosis, which includes touch or squash preparation. You take what you think is tumor, you don't put formalin, you put it in saline or in a wet gauze, send it to a pathologist who's going to put it between 2 glass slides, squash, and those cells, the cytology of those cells will give a clue. So they will call up and say, boss, that's fine. It looks like sarcoidosis or it looks like lymphoma. You've got some tissue. We should have a diagnosis. I think that's one of the most reassuring things for an orbital surgeon, so that you don't have to cut more and keep chopping and cause a complication. So intraoperative tissue diagnosis, particularly touch, squash, or slide preparations, have gone a long way in avoiding that negative biopsy and making your approach very safe. So that is one thing. We often don't use frozen section. This is another point that I think the students may note. The frozen section is very good for the lids because there are few diagnoses and you have to see margin clearance. In orbit, there is no margin. Orbit is a space. So frozen section is very, very rarely used in orbital diagnosis. And it's a Pandora's box. There can be anything there.
Dr. Ravindra Mohan.
Thank you, sir.
Yes,
I'm sorry. Yeah, who is asking? PG?
So, BNR, you can ask.
Yeah, no. Somebody was asking. So, PG student, can you stop sharing the screen, please?
Yeah, sure. Yes.
And my question is, what are the major complications you faced in your surgery and how did you manage it?
Sure. The major complications include, first and foremost, is bleeding. Now, bleeding is one of the most dreaded. In any orbit, when we start, we are always worried about bleeding. So as we discussed earlier, to get all the investigations to make sure at least the bleeding and clotting parameters are fine. So you're not dealing with a hyper, abnormal coagulation profile. So bleeding has to be controlled by two things. One is a good suction and very judicious use of cautery, because we can't deep without seeing, you cannot cauterize. Good suction, hypotensive anesthesia, of course, in general anesthesia, and use of certain materials. So what are those materials? The important ones are things like abs gel or gel foam, which I'm sure most people are familiar with, which can be put in and then we put pressure and wait. So the most important thing is to put pressure, wait, keep monitoring the pupil, and put materials like ab gel. And there's something called oxidized cellulose, which is Surgicel, which is like a gauze, small shiny material like a gauze, which is oxidized cellulose, that can be put in. And that will immediately stop general oozing. It will not stop a bleeder, but the generalized ooze will stop. If you're working with Orbit, for example, you're doing an osteoplastic flap and there is bleeding, there's another material which is commonly used, and I'm sure most DCR surgeons are aware of it. That's called bone wax. So we take the bone wax and rub it around so it enters all the small crevices in the bone and stops any bleeding. Because often what happens is the bone surface, where you cut the bone, the bleeders are deep inside. Your cautery is not going to reach, your pressure is not going to reach. In those cases, bone wax is also useful. So these should be available. What Subudhi sir has asked, I think is very important. Before you go into orbital surgery, please have these, and these are not expensive. All these items are very, very affordable. And if you're working in a hospital which has other services, your ENT friends, your plastic surgery friends, gynecologists, they handle much more blood than we can ever imagine. So they will also possibly be able to help you with these materials. And if your bleeding is not stopping, they're always good. And the anesthetists are always very good in bleeding, much more than ophthalmologists.
So there's another drop which is used to stop bleeding, which is known by botropase. That is a snake venom, yes, kind of a diluted solution which is put to clot the areas.
Right. I have no experience. I think Anirban or Dr. Gyan or pronouncer.
DCR cases, I'm using that a long time, and it really works. Okay. DCR, DCT, it really works. Actually, my wife was using in the gynecology this thing, cesarean section. So from that, I carried it over to the ophthalmology this thing.
Yeah, that's a good partnership, right? So
learn
from each other.
Iravind Mohan, sir.
Yes, sir.
Sir, often we encounter a problem sent by our neurosurgeon. Tumor was removed from intraorbital tumor, and patient is post-operative suffering from the dystropia and ptosis. When to intervene, sir?
Right. So I think the neurosurgeons should take us into confidence many times. You have to form a good team with them and maybe even to step into the theaters, because often they have not looked at when you remove the roof. So they can approach the eyeball only through the roof. That's a panoramic view where they remove the roof and then they look around, and the levator, the levator muscle, the levator superrectus complex is very, very amenable to being damaged there. So if the surgeon is very confident that they have not damaged or cut the levator muscle, then it may be something like what we call as a neuropraxic injury or some kind of a stunning of the muscle, which may reverse. But I think that reversal is not going to happen in after a few weeks. So not longer than 6 months. Beyond 6 months, nothing is going to happen. But if the surgeon is very good friend of yours and is very honest and they say that, well, I saw something red and I just cut it, then obviously you can actually go ahead and repair it. So early repair is also a possibility. You can go through a lid crease incision, explore, and you may find that the levator has been actually cut, which has happened in 1 or 2 cases that I have handled. And then you can repair it. And the repaired levator starts working very well. Within a few weeks, the ptosis will go away. So I think sometimes neurosurgeons often deal with very difficult situations. So this is not something that I'm making light of it. But for example, with the facial nerve and with other nerves, sometimes they know that they have not damaged it, but still the facial palsy happens. So in that, we just wait and wait. We say we've been very gentle, do not damage it, often the function will come back. So similarly, in ptosis also, if you have an honest discussion with them, they say they've been very careful. The biopsy doesn't show any muscle, for example. In some cases, I've seen that the biopsy itself shows muscle, which looks like levator. If it doesn't show, then we would wait and reassure the patient that things will improve. And often, within a few weeks, things should improve as well.
Thank you, sir.
Dr. Jaita,
Sir,
do you have
one more
any
question.
comments? Yeah, Professor, continue.
Yes, sir. Sir, actually, how can we prevent Steele syndrome, which occurs usually while removing cavernous hemangioma?
Yeah. So I've been very fortunate in not personally, touchwood, encountering Steele syndrome, but the ways of which are very gentle removal, right? You do not, you see the thing and you just remove it. So often you should dissect all around and separate it from any adhesions. So because Steele syndrome is a concept, nobody's seen the optic nerve blood being stolen. It's a concept when the surgeon has been very careful, very gentle, and still the vision goes up, right? So it's like a idiopathic kind of a diagnosis. So the way to avoid any damage to the optic nerve is by being extremely gentle. So one, your imaging is today of such high quality, you can make out if there's any adhesion or if there's any fat in between. That is one way, preoperative. Second, intraoperatively by seeing the movement. When with the orbital dissectors, we gently move, then we look at the pupil. We also look how it is in addition to the optic nerve in terms of how it's, often it will look it's next to it, but there will be a plane, right? So gentle removal. So the moment you see it, you just try to pull it out. No, so we don't do that. So that is the only known way. Still, if the patient loses vision, then the orbital surgeon usually blames it on the Steele syndrome.
Sir, Joyita here.
Hi, Joyita.
Yes, sir. Sir, can you tell us something about vertical lid split? Are you doing still now?
Yeah. So vertical lid split, I think I have done exactly 2 patients with a vertical lid split. I know it's a very popular incision that people have described. The vertical lid split is a very good. So I'll briefly describe it for the young students who are attending. The vertical lid split involves a vertical incision translid. So if it's like this, if this is the lid, you cut it and split it into 2 vertically, completely. Now, normally you would avoid doing this in the central part because even if you repair it well, if there's a mild notch, you don't want it really in the center. Once you open up the lid like a book, you can go into the fornix and you can go into the entire superior orbit very well. So the only case, I mean, offhand I can recall is the superior hematic cyst of the orbit. So there's this patient who met with a road traffic accident and started developing downward displacement of the globe and proptosis, which is growing, quote unquote. So these hematic cysts can grow. So it's not a tumor, but behaves like a tumor because this collection of blood under the periosteum starts breaking down into the components and the hemoglobin breaks up. So as the number of osmotic particles increase, it will attract more fluid. And so this tumor will become larger and larger and grow. But the actual etiology is it is a hematic cyst. So this was a large hematic cyst in the superior orbit, which I removed because I could think of no other way where I could access right up to the orbital margin and the superior orbit. So the other case I think was again.
Can we do a endoscopic approach for that?
For a superior one?
Yeah.
Superior one,
instead of going for a lid split, vertical lid split, and that will be much more traumatic there compared to.
Yeah. No, today maybe I would have gone transconjunctival and removed it, but again, it's a large, dense, large cyst, and
that's why it is much more easy. If it is a small cyst, it's very
endoscopy. There are ways of endoscopy in the superior area, but for example, what we use for lifting up the brow and things like that. But I have not come across anybody using it because the globe is a scary thing nearby. So vertical lid split, good approach. And as good oculoplastic surgeons, we know how to put the lid back very well without a notch, and we have a nice pout at the end of it. So it's good if it's a large lesion, the superior orbit. I think it's a good approach.
Joyita, are you there?
Yeah. Joyita is there. No, she spoke.
Yes, sir.
Am I audible?
Yes, sir.
Yes, you are.
What is your experience with the superior lid split?
Vertical lid split.
Vertical lid split.
Yeah, I have done quite a few actually in the earlier times in my career. Supero-nasal intraconal spaces, I can easily take the mass out from this by vertical lid split. But now I have reduced the number, so transconjunctival is much more. And apical lesion, medial apical lesion can be very nicely taken out to vertical lid split.
It's a huge exposure because
yes, sir.
There is no lid there.
Exposure.
Yeah, there's no lid at all. You open it like a book, you are
Yes,
into the
sir.
fornix, and then you can do anything. So it's good in that sense, it's panoramic, but of course,
But
the
it
scar
is
never becomes
surprising
invisible.
What is surprising is that in spite of violating everything that you taught us about the Langer's lines,
Yes.
the lid split incision heals very well.
Yes, sir.
So it's actually cosmetically very good. So it's basically you're opening up the lid and then having a very good exposure in which is the transconjunctival approach. And the best part is that you don't damage the vessels as well as the superior oblique muscle which is there in that quadrant. So that is what used to bother us when we used to go sub-brow into that area. So the lid split is actually a very good addition for superomedial lesions.
And you're going along vertically.
Absolutely.
So which are the cases where you use it, Anirban?
Only for superomedial lesions. So I was hesitant because I had not seen that approach before. Then once I realized that it's actually quite an easy approach. It's a go-to incision now for those areas. Otherwise, exactly what you said.
At least,
medial is always transconjunctival nowadays.
You say medial intraconal, medial intraconal, especially the superior nasal point is very.
No, medial intraconal. How do you do it? So what I would do is I would go transconjunctival, disinsert the medial rectus muscle.
That's in
I had to go between the medial rectus and the optic.
Transcaruncular, transconjunctival, depending on where it. The other advantage of any conjunctival is you can extend it. You can start with a small one quadrant, and if you see the tumor is larger, you can extend it a little here and here. Correct. So you can. It's a titrable kind of incision.
Shashmita, you want to ask something? Yeah.
So I have two questions to ask. My first question is, why can't we give the incision over the eyebrow? And another question is, can we try these orbitotomy approaches for the repair of fractures, orbital fractures?
Absolutely. So
the first one.
Both this. So the first one is why not the brow? See, the brow is a hair-bearing structure, right? So any incisions, any scar on that has to be planned extremely well And despite that, you may damage some roots of the lashes, and the brow, part of the brow which is missing in lashes is very bad. So some patients will come for a brow plasty. They have a bad scar. So we've done brow plasties for that. So I would not want to go in. There are some neurosurgical approaches which go via the brow itself. But I would not like to do anything, because you are actually, the further you go, suppose you're taking an incision here, you need to travel that far, and your field is going to be that limited. You need to dissect so much more. Correct? Yes. So that is one of the advantages of a fornical conjunctival, because you're close to the ray where you are. So your arc length and your chord length and all that, which we learned in mathematics, that is much smaller. Whereas if you go here, you have to make a big incision to reach a smaller. That's one thing. The second thing you asked about fractures. So today, in the hospitals where I'm associated, any floor fracture is repaired along with me by the facial-maxillary surgeon through a transconjunctival approach. When I'm not available, or there's some other reason, and they're doing multiple other fractures, they may go subciliary. So transconjunctival is a beautiful approach for fractures. Patients are very, very happy, because you've not given them any more scar. And once you retract with a canthotomy cantholysis, you can repair the whole medial wall floor. Floor with the canthotomy and inferior cantholysis and a transconjunctival in the inferior fornix. And if you extend it transcaruncular, the medial wall. So medial wall, floor are the most commonly repaired fractures. Lateral wall fractures often don't displace and may not need. Even if you need a lateral wall fracture, you can always go transconjunctival. For example, I do my orbital decompression for thyroid through a transconjunctival approach for the lateral orbit. So it's possible, but often we don't repair lateral orbital fractures. Roof fractures are not in the realm of oculoplastic surgery, because often they will have other brain injury and all that. So we just keep away from that, and we don't give them access as well. So yes, these approaches are very good for orbital decompression, for abscess drainage, for fracture surgeries.
So another question, sir, do ophthalmologists also do the brow plastic?
Oh yes, why not? See, now everybody is trying to increase their area of, right? So I'm relatively conservative, but people are going into the mid face,
different
little bit chin, and then into the neck and the platysma. So brow is very much in our domain. And some of the operations you do are in other people's domains also, right? So facial-maxillary will do fractures, you will do fractures. Plastic surgeons will do even ptosis surgery. So it's all what you are trained and what you want to do, right? Brow is in our area, definitely. Overlap, but we do.
Right.
I think it's now like time for close. Okay.
So can we have 2 words from our President-elect, Dr. Jayanto Barua, sir? He has joined us.
Yeah. Sure.
She's silently sitting. Shall I unmute, sir?
Unmute, sir.
Unmute yours.
Yes, sir.
Very interesting and very, so to say, learnable things that I have learned today. This is not my field, but I do some of the surgeries. But today, this discussion, this teaching was a great one. That's all I have to say. Thank you.
So thank you, Dr. Ravindra Manji. I think it's again.
Sir, one more question I have. Actually, sir, as you said that transconjunctival approach is better and nowadays it is practiced. Sir, comparing transconjunctival with transcaruncal, like both are bloodless and both are minimally invasive. So out of them, like which is more preferred? Like when we are deciding the option for surgery, which is better?
No, but what is your idea? Wait, Ravindra, what is your idea about? Because he talked about all those things, no, how to select. So what is your idea?
Sir, like depending upon the location, like if it is inferior or middle.
Obviously, yes. After all the lecture, your question is already been answered. right? So you cannot say that this incision is superior to other. It depends on the location, how you can approach, what is the shortest route. Okay?
Yes, sir.
And I may add one line here. The caruncle is a small body. You just look at yourself in the mirror. So that is the only part. So isolated transcaruncular is almost never used.
Never
It will
used.
be very small, right? So the conjunctiva above, the conjunctiva below, the fornix, all that has to be incised. Because you're incising the area on the caruncular, you call it transcaruncular. So conjunctival is the generic, the overall overview.
Yes, sir. Thank you, sir.
Yes. Thank you, sir. Thank you, Dr. Abhinandanji. I think it's really a very good, nice talk, and it almost completes how to approach the orbital tumors and orbits. We thank you for coming to us twice and gave a really wide picture of this orbital approach. And I thank our moderator and panelists today, Dr. Gyan Bhaskar, Dr. Anirban, Dr. Jaita, to continue the discussion. And above all, our post-year students, yes, they have interacted very well and they're really inquisitive and they've asked a lot of questions. And I think we expect that this should continue from the post-year students resident. Thanks our president and president-elect be with us always. And above all, our mentor, Dr. Ajit Babu. So thank you all. And thank you, Rahul, for providing the platform. Thank you. We'll be seeing you again next month around 16th of July.
Intro not showing anything?
Yeah, Rahul is now not showing anything, yes. So with these few words, we close this episode and good night.
Thank you.
Okay.
Bye, sir.
Good night.
Bye,
Good
sir.
night. Thank
Good
you,
night.
everyone.
so much,
Good night, sir.
Good night, sir.
Bye, sir.
Good night, sir.
Good night, Rahul. Please close it. Right.